We're going to move on now to Associate Professor Susanna Park. And she is a current Associate Professor of Neuroscience in the School of Medical Sciences. She's a member of the Brain and Mind Centre's Forefront MND team. And her research is focusing on motor neurone disorders, chemotherapy-induced peripheral neuropathy, inflammatory and peripheral neuropathies, clinical neurophysiology and nerve excitability, clinical assessment tools, and motor neuron speakers. Many multisyllabic words in her description. So I'd like to welcome Susanna. She's going to talk to us about nerve damage following cancer treatment, translating research into practice. Welcome,
Thank
Susanna.
you so much for inviting me here to speak today. The cancer treatment landscape has completely changed in the past 150 years. So at the turn of the last century, there was virtually 0% survival. And due to dramatic advances in treatment, currently now in Australia, there's more than 69% of people diagnosed with cancer will live more than 5 years past diagnosis. And this survival rate is consistently increasing. And this means that there's a growing population worldwide, over 32 million cancer survivors worldwide, with over 1 million of these here in Australia. And this fantastic treatment success also means that we need to think critically about the long-term consequences of cancer treatment to promote quality of life in cancer survivors. So more than 50% of cancer survivors have survived colorectal, breast, ovarian, lung, or blood cancers. And these cancers are commonly treated with neurotoxic chemotherapies. And so these agents include platinum-based taxanes, vinca alkaloids, thalidomide, and bortezomib, and they cause chemotherapy-induced peripheral neuropathy. Chemotherapy-induced peripheral neuropathy causes predominantly sensory symptoms: tingling, numbness, pain, discomfort. And this causes functional problems: difficulty manipulating objects, problems doing up buttons, typing, texting, balance, walking, and coordination problems. And we know that chemotherapy-induced peripheral neuropathy, or CIPN, reduces treatment tolerability, and it's actually one of the leading causes of dose reduction or premature cessation of treatment. And increasingly, we're understanding that it might produce long-term side effects as well. There's currently no method to identify which patients are particularly at risk, and there's no quantitative and functionally relevant assessment tools. And most of my presentation today is going to focus on the development of assessment tools for CIPN. There's also no effective neuroprotection, and that's obviously the ultimate aim: to develop something that could prevent this damage from happening while people are receiving their cancer treatment. There are many potential mechanisms that can cause a neurotoxicity, and this is a diagram of the peripheral nervous system. And you can see that there are many postulated sites of toxicity throughout the nervous system, from the dorsal root ganglion to the distal nerve terminals. And it's going to be really important to understand the specific mechanisms per different class of chemotherapy agent in order to design effective neuroprotective strategies. And in recent years, we've learned a lot more about the molecular underpinnings of neurotoxicity from these agents. However, critically, in order to develop these neuroprotective strategies and therapeutic approaches, we're going to need to be able to translate these findings into the clinical setting. And this is going to require appropriately sensitive outcome measures and assessment tools. And so for this translation, which is the great theme of today's symposium, in order to translate these knowledge about mechanisms, potential biomarkers, and therapeutics from the basic science setting into the clinical research setting, and then ultimately into treatment advances for patients in clinical practice, I'm going to argue that assessment tools are critical to this process. I'm going to tell you about how we can assess the impact of CIPN in our research to date, how we can design optimal assessment tools, and critically, how we can translate these advancements into clinical practice and improvements for the quality of care of cancer patients. So the impact of long-term neurotoxicity in cancer survivors is quite significant. And so we did an online survey of almost 1,000 Australian adult cancer survivors that were treated with neurotoxic drugs. 77% of them reported current neuropathy symptoms, and this was 3.5 years post the end of their cancer treatment. And we found that severe neuropathy was associated with worse quality of life, more comorbidities, higher BMI, and greater pain. And we also found that patients reported balance, walking, and gait abnormalities. We also wanted to look at the impact in childhood cancer survivors, and this was a study in conjunction with pediatric neurology and oncology colleagues. And so we found that in 121 childhood cancer survivors that were more than 8 years post their cancer treatment, and quite a young cohort, we found neurological abnormalities in 35% of the group and a reduced sensory amplitudes in 24%. And taken together, this suggests that nerve damage following chemotherapy is a prominent issue in both children and adults. So it brings us to the question of how best to quantify chemotherapy-induced peripheral neuropathy and why accurate quantification is so important. So critically, in order to develop appropriate neuroprotective strategies, we need to be able to measure the potential benefit of these strategies. And so we need robust, relevant outcome measures. Currently in this field, there's a wide variation in outcome measures. So a recent systematic review identified over 117 different assessment tools. And this really leads to a lack of replication between studies, both in clinical trials and also in risk factor studies as well. And we also know that there's a gap in terms of translating these assessment tools that we use in research to be optimized for clinical practice. So we need to be able to use these tools to identify toxicity in routine clinical practice in order to assist clinicians and patients with treatment decision-making in terms of dose reduction. So looking at the current neuropathy assessment tools, the main one that is used is a clinician-based grading scale, which you can see here. And we know that these scales lack reliability, they lack sensitivity to change, and critically, they underreport neuropathy compared to patient report. But when we look at the number of validated patient-reported outcome questionnaires that have been developed to measure neuropathy, these have had really limited uptake in clinical practice, and they also lack the scoring guides to be clinically useful for clinicians to be able to use these in treatment decision-making. And this example just illustrates, I guess, why accurate assessment tools are so critically important. So this was a study that we looked at identifying genetic risk factors for neuropathy in a large international clinical trial cohort. And importantly, in this trial, they used both clinician and patient-based outcome measures. And when we compared the clinician-graded neuropathy with the patient-reported neuropathy, we found that there was a significant discrepancy. And here you can see a diagram of the proportion of patients without neuropathy. And with increasing cumulative dose of the neurotoxic drug paclitaxel, you can see that more patients report neuropathy. But there's this widening gap between the clinician perception of the patient symptom and the patient perception. And when we looked at genetic risk factors in this cohort, we found different predictors for the patient versus clinician reported outcome. And this really underscores that perhaps this difference in phenotyping methods between studies might be responsible for the lack of validation of prior genetic and other risk factor studies in this area. It really underscores why getting the assessment tools right is so critically important. So that brings us to the question of how we should measure nerve damage and which assessment tool is best. So we've been undertaking a study over multiple years, and this is work done by Tiffany and Hannah from my group. In 859 cancer patients treated with neurotoxic chemotherapies, we used a whole range of assessment tools. So patient-reported outcome measures, measures of sensation, clinician grading scales, nerve conduction studies, as well as neurological grading scales, which use things like pinprick and vibration sensation to quantify neuropathy. And it's what we found was that all of the tools were able to discriminate between no neuropathy and significant neuropathy. But when we looked at the responsiveness from pre-treatment to mid-treatment, so in that early toxicity development phase, is what we found was the patient-reported outcome measures, as well as the neurological grading scale, had really high responsiveness to change. So this means they can pick up early changes. However, interestingly, the sensory functional measures, as well as the nerve conduction studies and the clinician grading scale, didn't have this high responsiveness. And critically, responsiveness is a really important parameter to pick up these early changes. So the fact that patient-reported questionnaires and outcomes are responsive indicates that they're likely to be appropriate to pick up these early changes in clinical practice. And this raises the question, how can we achieve this clinical translation? So a current study that we have ongoing, funded by Sydney Health Partners, is to look at the feasibility of enhanced clinical screening with patient-reported outcome measures for CIPN. And so we're using 3 brief patient-reported outcome screening tools, and we're using multiple formats, including a variety of electronic means of data collection. And we're hoping to demonstrate that this can feasibly be implemented in the clinic to improve the early identification of neuropathy. Importantly, we also need to think about what happens when neuropathy is identified. And so we're currently developing a clinical pathway which will guide appropriate screening as well as management and triage pathways, so that when neuropathy is identified, there's a systematic way to treat these patients for best practice. The last thing I want to talk about today is how assessment is also critical for clinical trial outcome measures. And so we know that using multimodal outcome measures across a variety of fields improves trial quality. And so this was a study we did of exercise-based rehabilitation to see if people with established neuropathy could have improvement in their symptoms with a tailored exercise and balance training intervention. And we used a whole range of assessment measures, so neurological grading scales, patient-reported outcomes, balance tests, mobility, disability, and quality of life measures. And this trial had an 8-week waiting period and then an 8-week active exercise period. And what we found was improvements in patient-reported neuropathy in the 8-week exercise period, and also improvements in the neurological grading scale in the exercise period, as well as a suite of improvements in a whole range of other patient-relevant domains, such as disability and balance. And we're currently undertaking a phase 2 randomized trial of our exercise intervention. And this really underscores that by using these multimodal and patient-relevant outcome measures, we can pick up significant outcomes that are important to patients. So I hope today I've demonstrated that nerve damage following chemotherapy is a common side effect in both children and adults, that assessment tools and getting assessment tools right are really critical for the development of improvements in clinical practice and in research, that we need to translate these tools for use for better screening to guide patients and clinicians in treatment decision-making, and that these kind of outcome measures are also critical as clinical trial and in biomarker studies to improve our understanding of chemotherapy-induced peripheral neuropathy and ultimately to improve quality of life in cancer survivors. So thank you very much for having me here to speak today.
Thank you, Susanna. What a large body of work you just covered in a very eloquently in a very short period of time. So thank you for keeping to time. I do have a couple of questions for you. It seems to me like these neuropathies are quite complex with many different areas where they impact. And I noticed one of the areas you mentioned was hearing loss and buzzing noises and more sensory issues. And I was just wondering, I mean, I'm a speech pathologist by background. Is that something that I was thinking about, all the different referral pathways that must exist for these individuals once you're identifying the problems? Is that something that you would refer to an audiologist with those kinds of issues?
Yeah, certainly. So some particular chemotherapies are very associated with hearing side effects. So particularly cisplatin is really associated with a large amount of very long-lasting hearing damage. In fact, cisplatin is used in testicular cancer, and that's one of the most curable cancers, and often occurs in very young males. So you have a really long duration of survival. So there's been a lot of work looking at, I guess, appropriate screening and referral pathways, particularly for those patients treated with agents that cause sensory neurohearing loss.
So along that line then, having had a family member with that, what education is provided to cancer survivors about the potential long-term effects? Because I don't recall that one coming up in a discussion. So I'm just wondering.
There's definitely a gap. And in fact, we have a lot of our patients say, I wish that I had known about this side effect earlier, or that they had been provided with more education. Obviously, there's a lot of side effects of chemotherapy, and so you kind of have to tailor that to the particular cancer type and the particular agents. But there's probably a lot more we can do to improve patient education. And we have a number of consumer research partners that work with our group to try to advance that education. And I think the Cancer Council, I worked on them with a resource last year to develop a sort of patient guidelines for peripheral neuropathy and what patients should understand. So I guess that's only come out last year. So it's sort of increasing work in this space.
Mhm. Yes, I've got one question here from Peter Erling saying, is there opportunity to change chemotherapy if CIP is detected during the treatments? And thank you, it was a very good presentation.
Thank you. Yes, it really depends. So these drugs are used across a variety of cancers, and in some cancers, there are multiple types of therapy, lines of therapy that can be effective. And also it depends on whether the treatment is in the adjuvant setting, so in a curative setting, or in metastatic cancer. I think, I guess is what I'm saying is it depends on the specific situation, but certainly there are multiple examples where the chemotherapy regimen can be changed due to neurotoxicity. And in fact, for oxaliplatin treatment for bowel cancer, neuropathy is one of the, I think it's the second most common reason for premature chemotherapy cessation. So if the neuropathy becomes intolerable, then oxaliplatin will have to be dropped from the treatment regimen entirely.
Well, thank you very much for your presentation today.